Welcome to Post and Schell's webinar, COVID-19 and Telehealth Guidance for Healthcare Providers. In a moment, I'll turn the call over to Robin Locke-Nagel, the co-chair of Post and Schell's Healthcare Practice Group. Just a quick reminder, again, you are on listen-only mode. Your lines are muted. We'll be handling Q&A at the end of the program. You can submit a question using the Q&A tool in the Zoom toolbar that you're viewing now. If you're on the line, please feel free to submit any questions you have that we're not able to take via email to pjohnson@postshell.com. With that said, I'd like to turn the call over to Robin. Robin, please go ahead.
Thanks, Paul, and good afternoon, everyone. I know many of you that have joined the call, and a personal hello to you. I'm so glad that you've all joined us today. I hope you find a comfortable spot in your home or office, perhaps get some lunch, and are prepared to spend the next hour and a half with us talking telehealth. For those of you who don't know me, I'm Robin Nagel. I'm principal and co-chair of the Healthcare Practice Group here at Post and Schell. And I'm joined today by Cindy Haynes, who's principal and co-chair of the Information Privacy and Security Practice Group, and Amalia Romanowitz, who is principal in the Professional Liability Department and litigator extraordinaire. This is the first, actually the inaugural of our Women of Post and Schell webinar series. We plan to do several over the course of the year, covering many different topics in all of our many practice areas. And we're very glad that you joined us for this one. Paul, could you advance the slide, please? So just an overview of what we'll be talking about today. I'm going to set the stage by talking about the legal framework, both a little bit about pre-COVID and then mostly about now that we are in the COVID pandemic environment, the federal healthcare waivers, the state waivers that have opened the door to the incredible proliferation of all kinds of healthcare and professional services delivered via telehealth. After I set the table, so to speak, Cindy Haynes will then drill down into the challenges of operationalizing telehealth services in this environment, spend a bit of time on the privacy and security requirements, which are significant, and also talk through some contracting hot topics and challenges once you are actually in the mode of implementing the telehealth arrangements. And then finally, Amalia will be talking about liability exposures. And of course, we'll be sharing the very good news that I'm sure you've all heard, that yesterday Governor Wolf signed a partial immunity order protecting individual healthcare practitioners who are dealing with a COVID emergency on the front lines. It's not everything one would ask for, but it certainly is a start in terms of protecting from those liability exposures. Next slide, please. So just to kind of set the stage, there are a variety of ways in which professional telehealth services are provided. The gold standard is the real-time interactive two-way communication using visual and audio capabilities. In this environment, increasingly, I think Medicare, CMS is recognizing, and other providers that it's not always possible to get the audio visual. And so much of the telehealth services are being provided by audio only. But of course, having the visual component is very important when it's possible. And then the second form, of course, is the asynchronous store and forward, radiology studies, pathology studies that are taken and forwarded digitally to a provider who evaluates them in a remote location. And then the third is the remote patient monitoring, where a device is actually set up for an individual patient to take their blood pressure, their pulse, respirations, and so forth, and communicate that data to the provider in a remote location who uses it to make the diagnosis. And then a whole host of mobile medical devices that are being used to as part of the delivery of telehealth. Next slide. And Medicare, even before the COVID emergency, was providing some reimbursement for telehealth services. It was much more limited than it is now. The providers and the locations where it could be provided were very restricted, but they did, in limited circumstances, reimburse all three categories of visits that you see on the screen. The first being the Medicare telehealth visit, typically E&M evaluation using the real-time two-way audiovisual technology. The second category being the virtual check-in, which could be a brief check-in by telephone or otherwise, just to decide whether an office visit or service is needed, or it could be evaluation of the store and forward technology studies by a remote practitioner. And then the third category, it was an e-visit, is an e-visit, which is communication through an online patient portal. But the locations were very restricted pre-COVID, and what's happened now, of course, is that the CMS at the federal level and the state governments at the local level are encouraging telehealth to be used in virtually every context, so that it is needed healthcare services can be delivered by providers to patients without the need of the face-to-face contact, and all the way to providing the service to the patient in their home from a provider who is in his or her home, providing, reviewing the information and providing the service, and then billing it to their practice location. And of course, at the federal level and the state level, we are now able to practice across state lines, which is also critically important in terms of expanding access to the service. Next slide. So how did we get to where we are? Well, it started with the CARES Act passed on March 27th, and there are really two major things that the CARES Act did in terms of telehealth. The first was an infusion of federal funding to help develop the telehealth infrastructure. Under Title III, Congress authorized nearly $150 million in new grant funding under the Public Health Services Act, directed specifically at underserved and rural community development. And then under Title V, Congress authorized an additional $200 million to the FCC to help build out the telehealth infrastructure that is needed as quickly as possible during the COVID emergency. And then in addition to the funding infusion, Congress removed certain statutory and regulatory barriers that had existed previously that was inhibiting the growth of telehealth. And the most important was Section 3703, which expanded CMS's Section 1135 waiver authority to include telehealth. And Section 1135 is, of course, the provision that says that when there is a public declared emergency, the federal agencies can use this authority to waive certain regulatory requirements that are standing in the way of addressing that emergency effectively. And it is through this waiver authority that CMS has, broken down so many barriers to telehealth. But there were also some other statutory amendments that were required. I'm not going to review them all on the slide, but it gives you an idea of the range of things that had to be done in order to facilitate the moving forward of telehealth. Next slide, please. But the important thing are the blanket waivers. And of course, a blanket waiver means that it applies to everybody in the particular category. You don't have to apply individually to CMS to get the waiver. There is also provider-specific waiver authority out there, and many providers have approached CMS for specific waivers going beyond even the blanket waivers, and they have been sympathetic to those applications. The most important, of course, for telehealth purposes is licensure. So practitioners are no longer required to be licensed in the state where the patient was located. So long as they are enrolled in Medicare, they're validly licensed, they're furnishing services in a COVID emergency location, and of course, they're not excluded from practice for some other reason. So those are the basic requirements by CMS. Now, you also, of course, have to look at the state licensure restrictions as well, and we'll be talking about that in a moment. Hospitals to do telehealth or telemedicine do not need a written contract with their contractors, so those portions of the COPs have been waived. CMS has also waived those portions of the conditions of participation that related to hospital credentialing, so you no longer have to look at those provisions. Still, of course, state law requirements are in place unless waived, and facility requirements are, so it doesn't mean that you can just breeze in to a hospital and start practicing, of course. Under EMTALA, emergency patients are not required to be screened in the emergency department. They can now be screened remotely via telehealth. There was an easing of restriction for verbal orders, again, to facilitate necessary orders delivered via telehealth communication. And a related requirement is that in states that permit it, hospital patients are not required to be admitted under the care of a physician. They can be under the care of an allied practitioner if permitted by state law. Next slide. And so there are also a number of waivers that are relevant to telehealth and have facilitated telehealth in the delivery of a variety of different specific locations. For long-term care facilities and SNFs, the in-person visits by physicians and APPs can be delivered via telehealth. In SNFs, physicians can delegate specified tasks to qualified allied health practitioners who can also provide those via telehealth. In the home health context, again, initial assessments and also biweekly nursing visits can be conducted by telehealth. And in the hospice context, the biweekly on-site nursing visits can also be provided by telehealth. So again, expanding in a very substantial way the various settings in which services can be provided. Next slide, please. In dialysis facilities, similar kinds of waiver of restrictions, monthly in-person physician or APP visits to in-center stable patients can be done by telehealth. The quarterly in-person visits to home dialysis patients can be done by telehealth. And some other relaxation of requirements. The credentialing is transferable so that if a practitioner is credentialed at one Medicare certified facility, they can practice at any Medicare certified facility as far as CMS is concerned. And the DME POS can also be replaced without face-to-face visits via telehealth. Next slide. So that is kind of a very quick overview of the ways in which CMS has authorized telehealth services in a whole host of different settings. Even though I didn't focus on it, it is important to know that one of the most important relaxations is the provision of services to patients in their homes, and that the provider can also be anywhere. They could even be in their own home or some other facility in order to provide the service. And by the way, I should mention that just within the last few days, CMS has issued a very extensive set of supplemental regulations that drill down in extraordinary detail on the coding that needs to be done for these various types of visits, coding by physicians, by nurses, in all these different types of facilities. And for instance, one of the things that they clarified in this new guidance is that where they had previously said that the physician, say, who was at home, whereas he would have ordinarily have been in an outpatient hospital clinic, if the physician is at home providing services to the patient at home, the physician can bill. That was established previously, but now CMS has clarified that the hospital can also bill its facility fee that it would have earned had the visit taken place in the outpatient department, in recognition of the fact that there's obviously costs that the hospital is incurring here, even though the service is being provided via telehealth from home to home. So that is a wealth of new information. And for those of you who are actually, providing these services and billing Medicare, you really need to consult those new regulations. So moving on to the Stark waivers, there are a whole series of Stark waivers that CMS has also issued that facilitate the provision and build out of telehealth in a variety of ways. One of the chronic issues has always been for telehealth providers is what if the recipient, be it a community hospital or a rural health clinic or, a physician practice, whatever it is, what if they can't afford the telehealth equipment that is needed in order to provide the service? And so the waivers, and again, they're obviously not directed specifically at telehealth, but they're very helpful in this context. Establish that it's okay to provide telehealth equipment for free. It's also okay to issue, I'm skipping one, to issue low interest loans to help establish telehealth. And the one caveat, and I think Cindy's going to be talking about this a little bit, but the one thing you have to keep in mind is these Stark waivers, as with all the waivers, are only in place for purposes of the COVID emergency, and they're going to go away when the emergency is lifted. So in terms of how to use them and implement them, you need to think about the long-term picture, not just the short-term picture. It's okay under Stark to waive copayments and deductibles for telehealth services, again, to make those services more accessible to patients. It's okay to negotiate physician contracts at either above or below fair market value, as the case may be, and that may be necessary to get physicians involved, either as the providers or the recipients of these services. The non-monetary and incidental benefits limits have been waived for purposes of the COVID emergency, so you can provide more than the $300 or $400 and some dollars that would be permitted in regular times. And it's also okay, and this is specifically directed at telehealth, the in-ancillary services exception, which authorized referral for DHS to another provider in the same practice, but only if it was physically located in that building or immediately contiguous. That waiver has been lifted so that the patient can be referred for DHS by someone in the same practice, even though it's being provided in the patient's home or in a long-term care facility or SNF or somewhere else. So that's an important one. And then, of course, the unsigned compensation arrangement waiver. They're not going to be persnickety about making sure that all contracts are signed by both parties. So all of those are very helpful in terms of trying to work fast to get agreements in place that will facilitate telehealth during this period. But again, the caveats here are, this is not open sesame on Stark. The guidance makes it very clear that it's not only limited to the emergency, but it's also limited to those services that are necessary to provide service in this COVID pandemic. And so you need to be able to justify what you're doing that is subject to one of these waivers as by showing that without it, you really wouldn't have been able to provide that service in the same way. Next slide, please. And of course, you also have to remember in this context that the anti-kickback statute has not been waived. It's still in effect. Now, it's, as you know, not a bright line statute. We're dealing with safe harbors, not strict bright line requirements. So there's always some leeway. And I think that providers can take comfort from the 3 telemedicine or telehealth related OIG opinions that have been issued over the years under the anti-kickback statute. In each case, various forms of free equipment or reduced cost equipment was being provided to the recipient of the telehealth service. And there was a concern, of course, that that was an inducement for referring back to the entity providing the service, which was acknowledged by the OIG. But in each case, the OIG noted the safeguards that had been put into place to protect against fraud and abuse, and most importantly, pointed out that without this particular arrangement, the patient pool would not get the services. It simply wouldn't get these needed services that was facilitated through the arrangement. And I think it's pretty clear that in the COVID environment, a strong argument can be made in many, many different settings that if you don't move outside the safe harbor a little further than you ordinarily would, it's just not going to be possible to provide the service. Next slide, please. As I mentioned earlier, Cindy's going to deal with the HIPAA privacy and security issues, so I'm going to skip over that for the time being. But I also want to mention that there have been waivers by the DEA to help facilitate telehealth, the most important of which is the waiver of the in-person examination requirement for prescribing of Schedule II drugs. That's been in effect ever since the Ryan-Haight Act was passed about 10 years ago. But for purposes of the COVID emergency, DEA is waiving enforcement on that requirement so long as the Schedule II drug was prescribed for a legitimate medical purpose, not street sale, in the usual course of practice. The provider is acting in accordance with state law. It's through an audiovisual real-time two-way interactive system. So it is a real patient interaction as close as you can get to in-person evaluation. And with all those caveats, the Schedule II drugs can be prescribed. They've also relaxed some record-keeping requirements, such as, for instance, the requirement of informed consent, written informed consent prior to an emergency order, oral order being issued for Schedule II drugs. And they've also waived the state-specific DEA registration requirements. So if you have a DEA registration in the state where the provider is and is practicing, then that will be applicable in any other state where the provider may be providing telehealth services, as long as it's consistent with state law. So you still obviously have to meet the state law requirements, but you don't have to meet the DEA registration requirement. Next slide, please. So that covers very quickly all of the federal healthcare waivers, or the highlights of them that help facilitate the delivery of telehealth services. But it's important not to lose sight of the fact that there are many other regulatory requirements that come into play, most importantly, the state law requirements. And as I've said before, that this emergency is time limited and enforcement will resume once it's over. So with that said, can we go to the next slide? I'm going to spend a little bit of time on Pennsylvania, the state of play in Pennsylvania, and then in New Jersey as well. So Pennsylvania has no telehealth statute. We came very, very close last week, or within the last 2 weeks. SB 857 was enacted on April 21st after 4 or 5 years of back and forth between the Senate and the House, but it was vetoed on April 29th by Governor Wolf, and it was over an abortion rights issue. Last fall, the House, conservative House Republicans had tacked on an amendment that had the effect of making it impossible for a provider to prescribe mifepristone, an abortion-inducing drug, to a patient via telehealth. Governor Wolf swore at the time that he would veto any legislation that came across his desk with that provision in it, and he did in fact veto that law. So we have no telehealth statute. We have no guidance, no statutory guidance in Pennsylvania as to what is acceptable or not, or the parameters within which telehealth services may be provided. And Amelie is going to spend some time on the liability implications of that. What it would have extended to is a variety of specialties, not every regulated professional in the Commonwealth of Pennsylvania, but key ones: medicine, pharmacy, OT speech, nursing, and so forth. The licensing boards would have issued regulations within 24 months, setting forth the practice standards and the disciplinary provisions to regulate these services. And very importantly, the insurance plans issued in Pennsylvania would be required to cover telemedicine services, not necessarily at the same rate that the in-person visit would be covered, but at a negotiated rate that was agreed to by the insurer and the provider and filed with the Department of Health, subject to review by the Department of Health. So that provision, is not in effect. Now, the fact is that I think the commercial health insurers in Pennsylvania have actually outstripped both CMS and the Pennsylvania Medicaid program in terms of covering telehealth services, and many of them are already covered by commercial health plans, but it would have been very nice to have that additional protection. And then, of course, Governor Wolf somewhat redeemed himself yesterday by issuing the executive order that provides limited immunity during the COVID-19 emergency, but importantly, excludes facilities and excludes private practice groups. Could you go to the next slide, please? So this executive order provides immunity to a healthcare practitioner who's licensed, certified, or registered in PA and who's engaged in COVID-19 related services. So this is not anything and everything, it's COVID specific. In the following settings, they are practicing in a healthcare facility, nursing facility, personal care home, assisted living facility, or an alternate care site, community-based testing site, or a non-congregate care facility. So the practitioners are covered, but not the facilities themselves. And if they're practicing in any other setting, even if they're doing COVID-related work, they are also not covered. What does it protect them from? Civil liability for death or injury of a patient as a result of COVID-related professional services, except in the case of willful misconduct or gross negligence. It's effective immediately, doesn't say anything about whether it's retroactive or not, and I'm frankly not certain whether it will be applied retroactively, but it will be in effect for the duration of the disaster emergency. Next slide, please. State licensure in Pennsylvania pre-COVID, of course, you had to have a Pennsylvania license to practice any form of telehealth. That has been waived for purposes of the COVID emergency. And all you have to do is provide your contact information and licensure information to the appropriate Pennsylvania board, and the relevant boards are listed on the slide. Next slide, please. You can also, if you don't want to simply practice without a license, there are expedited procedures for getting a Pennsylvania license under rules of the State Board of Medicine, osteopathic medicine, nursing, and frankly, all of the other boards, or most of them, have issued expedited processes as well. And we have the link there on the slides for that. Next slide. And then there's a variety of other telehealth-related Pennsylvania waivers, again, just giving the highlights. There's waivers for hospitals to provide services at their off-site alternative care sites, including ASCs that may have been converted to alternative care sites through telemedicine. There's telehealth pharmacy waivers, among others, so that technicians can perform limited work remotely under supervision of a pharmacist, and so that out-of-state pharmacists can practice in Pennsylvania. There's mental health training waivers, so that certain categories of mental health workers can complete their training through telehealth methods and supervision, obviously to get them in as fully licensed practitioners as soon as possible. There's a variety of other education pushing waivers to get people out of graduate medical education programs faster, to get medical students out into the field faster, and so forth. There's expanded scope of practice for a whole host of specialties, some of which are designed specifically to facilitate more services via telehealth to patients in facilities. And of course, there's a telehealth waiver for remote consultation for medical marijuana. There's also an expansion of the Medicaid payment provisions. Medicaid was pretty narrow pre-COVID. It paid for telehealth services in the mental health field under both the fee-for-service and the Medicare, the Health Choices program, but it was not very broad. Now, of course, they're covering lots of services in lots of different settings. Next slide, please. So I'm just going to touch briefly on New Jersey before handing this over to Cindy. New Jersey does have a very complete and comprehensive telehealth law. It permits the full range of professional services recognized in New Jersey. So anything for which you can get a license or a certificate for or register to do as a professional in New Jersey, you can do via telehealth. And unlike the proposed Pennsylvania law, it actually provides explicit provider protection from disciplinary action based on the fact that they are providing services via telehealth. So that's an important protection for providers in New Jersey. Of course, it requires New Jersey licensure in ordinary times, but the New Jersey has waived the licensure provision so that out-of-state providers can treat New Jersey patients within their scope of practice. If they're existing patients, they can continue providing the existing services or really for any service for that existing patient. But for new patients, services must be limited to COVID-19 diagnosis and treatment. So many out-of-state providers want to secure New Jersey licenses that will allow them to practice more broadly. They can do that through an expedited process, again, with a waiver of a number of administrative requirements to try to get them through very quickly. And the individual boards are authorized to and have waived additional requirements for New Jersey practitioners. Next slide, please. And so the New Jersey telehealth statute does have extensive clinical requirements, standard of care, establishing the provider-patient relationship, informed consent, and so forth. And the individual boards have then also issued, I think they're all in provisional form now, not final, but they've all issued additional requirements governing the practice of telehealth in New Jersey. So many of these specific statutory and regulatory requirements have been waived for purposes of the COVID emergency. There's a loosening of the restriction of the provider and where the provider can be and where the patient can be, again, so that you can sort of provide services from anywhere to anywhere as needed. There's a broad range of technological devices, and Cindy will, again, be talking about the security issues and the waivers related to those. They recognize that since they incorporated the HIPAA requirements into the New Jersey statute, they've acknowledged that those requirements have been waived and, to the extent of federal law. There are, however, as I understand it, state law privacy protections that are still in place in New Jersey. So they're not HIPAA, they're state law requirements that are still there. And they also acknowledge DEA's Schedule 2 waiver, but again, New Jersey built into their own statute the requirement of the in-person evaluation before controlled 2 substances. And as far as I know, that New Jersey requirement is still in play. Provisions relating to establishing the provider and patient relationship, establishing consent, what must be in consent forms. There were certain face-to-face requirements relating to federally qualified healthcare centers. All of these have been waived, and a variety of the Medicaid billing amounts and procedures, again, just to make it easier to do this during the emergency. But New Jersey makes clear you must still practice within the standard of care. They have also adopted an immunity statute that provides protection from civil lawsuits, but the expectation is that the providers are still practicing within the standard of care within the context of the COVID emergency, whatever that means. So I think that comes to the end of my section. Could we have the next slide, please? Oh, one more just comment. I mentioned that CMS had waived the facility credentialing requirements, but of course, the state law requirements may still be in play, and virtually every facility has activated its disaster preparedness plan and will be doing credentialing according to that plan. And obviously, individual providers need to reach out to the facilities where they want to practice and determine what those procedures are and follow them. So with that, and if we could now have the next slide, I'm going to hand it over to Cindy to talk about telehealth contracting.
We're going to go through telehealth and contracting. And as you see on this slide, we're going to talk about privacy and security, safety issues, system performance, data rights, interoperability and integration, intellectual property, risks and liability, and termination and transition. Keep in mind, we're looking at a long game here, but if you are putting in place telehealth contracts now, I hope that you're able to look at this as a checklist and think about these things as you move forward through the contracting process. Next slide, please. As Robin had alluded to, there are privacy and security waivers that OCR has put in place. What they say in a nutshell is that covered entities will not be penalized for good faith violations of privacy, security, and breach notification rules. Keep in mind, however, good faith violations. So it's important to understand that the privacy and security rules are still in place, and you have the responsibility to still work through HIPAA best practices, both with regard to privacy and security. Telehealth, in OCR's guidance, they indicated that telehealth must be an appropriate method for the service being provided. I recommend strongly, and I think my colleagues would agree, that it's very important to document what services are being provided, why it's appropriate, and if you are utilizing any kind of waiver, why the waiver is appropriate for those services. Next slide, please. Again, privacy and security rules have not changed. So it's important to think through what are current privacy and security rules and what might it look like and how would it be a little bit different for telehealth. According to OCR, some less secure communication methods are permitted, and some of these are easy. And as you all know, we've been using these even in our private lives, for example, Zoom, etc. In my view, it's very important that staff be trained, especially if they're working from home, as many of us are, on use of these communication methods, and also about some of the pitfalls. Are you in an appropriate place? Can your family hear what you're talking about? That would never be appropriate. So it's very important for entities that are allowing providers to use these types of communication methods, train them very carefully, and have policies in place for infractions of any kind of violation. Less private locations are permitted. However, again, patients should be notified of the risks, and also we should use all potential encryption and privacy modes that are available to provide services over telehealth. Additionally, patients, I think, training wouldn't be the right word, but they should be informed that, you know, they are telling us information that may be very private, and it's important to keep that in mind as they are having their appointment or receiving telehealth services. Next slide, please. When you read through OCR's information, they are very clear that they are not going to support any vendors in particular, but they do create a laundry list of types of vendors that do have compliant products and will enter into business associate agreements. Now, again, OCR has not certified that those are compliant products, but they did say that those vendors themselves hold themselves out as being HIPAA compliant and will enter into BAAs. As attorneys, in terms of providing services through any kind of vendor or provider, I would always recommend that you have a BAA because they are doing a service for or on behalf of a provider. So I believe it's important to do that. State law still applies unless it's waived. In Pennsylvania, some of the most important state laws are sort of around super data, that is mental health, drug and alcohol type of data. And that information, generally those terms are related to disclosures and releasing information to other entities, et cetera. And those provisions have not been waived at this time. But again, for telehealth purposes, I think it will be that that sort of data is not necessarily affected. Next slide, please. Privacy and security has not changed. The rules are still in place. So it is still incumbent upon a provider to be sure that only authorized users are able to have access to electronic protected health information. Again, this will have to happen fast, and I think OCR during this time of emergency has indicated that they will be understanding about certain privacy violations that are not necessarily breaches, but are in good faith, and especially when individuals, when you're in a hurry to get services in place. A system of secure communication should be implemented. So that is a matter of talking with your vendor and receiving certain assurances from the vendor themselves. Again, the gold standard is usually a warranty. If you can get a warranty and an agreement that they are secure systems, that's always the best. But during this busy time, it's something to think about and make sure that's in place in the future. Next slide, please. An important concept is privacy and security related to data storage. Many telehealth vendors will also be able to offer a cloud type storage or other type of storage. It's important in those instances to always have a business associate agreement in place, and also assurances that they have done their own security assessment. And the best, of course, is that they are certified and meet security standards of the ONC. Next slide, please. One of the things that should always be in place in a vendor agreement is the assignment of appropriate roles to both the provider and the vendor themselves. For example, who is going to keep logs, who is going to provide reports, what is access going to look like, and how often will you be able to receive that information. For many larger providers, health systems, for example, that information is very important in order to be able to secure payment and to also monitor the provision of services over time. Secondly, it's important to have provisions in a contract itself to ensure that providers are not prevented from reporting and discussing various issues, safety and security issues, in particular those issues that may be related to systems problems, downtime, especially for those types of services that have a direct impact, such as remote patient monitoring, where individuals are actually being touched by the equipment and the software is actually recording that sort of data or transmitting that data to the provider. Next slide, please. Good vendors will always offer to have some sort of maintenance and upgrade schedule and also to report on maintenance and upgrades to the provider themselves. It's very important in a contract with these vendors to allow for collaboration if there are any safety issues that are related to the software itself. And also to require transparency about these various issues. Again, vendors are loath to agree to taking any kind of clinical responsibility, which is, of course, very appropriate. However, if there's a problem or an injury that's related to a safety issue based on the technology itself, it's very important that the risk is on the vendor themselves. And again, this would be a great place to have a warranty. Next slide, please. I touched briefly on a security assessment. These off-the-shelf type of documents, or services that you will use, such as Facebook or Zoom meetings, you will not necessarily be able to get these kind of assurances. But I think for the long game, in order to look at telehealth as something that we're going to be doing for a long time, we're going to end up going back after the emergency to regular security requirements. It's important to look and require that they have their security assessment and that they perform regular audits. Most important, I think, for a large project is that it's based on ONC and NIST standards and have that written directly into the contract. Finally, encryption methodology, secure data retention, and ultimately destruction. If there is a storage prong to the telehealth, it's very important to underscore all of this in the contract itself. And again, it's always best to get a warranty for this for these types of provisions. Next slide, please. Systems performance. One thing that in doing contracts with electronic health record vendors and telehealth vendors, it's important to understand what their uptime rate is, how often there are problems and downtime. And for some of the remote patient monitoring, you're able to absorb very little downtime, and it's very important that that be very clear in the relationship and in the contract itself. One strategy for addressing that is to have service levels and service levels agreements whereby they would pay a credit if there was downtime that exceeded the service levels, with the opportunity, of course, to terminate the contract. Next slide, please. Data rights. It's always important as a provider that you are clear that you own all of your data and you're able to have timely and reliable access to that data, and that access can help you for analytical value, especially with regard to larger providers and with regard to payor relationships for any kind of provider. Finally, I think there should always be a restriction in the contract itself for the vendor to use data for any kind of commercialization unless both parties agree and it's mutually beneficial to both parties. Generally, it is not beneficial to providers, and vendors must be accessible. It's always problematic if there is overnight no ability to get in touch with a helpline or to talk with the help desk to get you up and running again after services are delayed, etc. There's a question, will the slides be available following the webinar? And we'll let Paul answer that. You can always email one of us too. I'm always happy to share the slides. Interoperability and integration. These are words that are often thrown around, but I can't emphasize enough how important this is, that when you're going through your testing and acceptance of various types of software and also various types of equipment, that you be sure that it's interoperable and integrates with both your EHR and any other type of third-party technologies that you rely on and must use. So that's a very important provision, and again, we like to see that in a warranty. Next slide, please. Many times providers do not necessarily think about this, but if you are doing something creative with your vendor And if you have had investments with a vendor in customizing or improving software or equipment related to these processes, including telehealth processes, and this is an important thing, I think, to think about right now at this important juncture when everyone's looking to improve these types of communications. Think, do we want something in the contract that protects us if we do work collaboratively with the vendor so that they alone cannot profit? I mean, you always want something to be fair, but I think it's important to understand that your sweat and tears that go into a collaborative relationship may be worth something too. Again, other standard intellectual property terms, such as the indemnification terms, and also the infringement terms should be in these agreements. And again, we like to see those in a warranty. Next slide, please. Risks and liabilities. Of course, risks should be allocated fairly between the parties. Who has control over a particular situation and is able to mitigate the risks. Oftentimes, vendors will offer an arbitrary cap, like a year's worth of payments, etc. It is okay to negotiate a cap on your liability. However, we always recommend that personal injury, breach of privacy, willful misconduct, that those are carved out of the limitations of liabilities. As we all know, regulations around privacy and HIPAA can get very costly and expensive, and generally the vendor, in an instance where it's a system-related type of breach or exposure, the vendor will have some part in that exposure. So it's very important to look at that as a carve-out. Next slide, please. Termination and transition. As you go through and create your contract, it's important to think about what happens next. What happens when we're moving on to the next provider? How will that look and what will that be like? To make sure that you have support to go through that transition, that you're not able to get bludgeoned by price increases during that time period, and also that you're able to receive your data and are able to convert it so that the next vendor may be able to use it. Next slide, please. And I will turn it over to Amalia. And thank you again, and sorry for the delay there.
Thank you, Cindy. And I'd like to reiterate my thank you to everyone who's participating today in our webinar. What I'm going to be talking about today is the professional liability concerns that can carry forward with the use of any type of telehealth or telemedicine services. And as Robin advised earlier in the presentation, there was a Senate Bill 857, printers number 1388, which was on Governor Wolf's desk, and on April 29th, 2020, he vetoed the bill. But he does have language in the veto which suggests that he supports legislation on telemedicine, and in the future, if the appropriate amendments are contained within a bill, he would consider signing it. So what I'd like to do is discuss with you today some practices that are identified in this proposed legislation. It's been several years now that the legislation's been tossed around, and I think that they contain some good practices and some things that we should all consider when providing telehealth services. Next slide, please. As Robin stated, there is no law today in Pennsylvania which authorizes or prohibits the practice of telemedicine. And so, you know, when those types of services are being provided, it should be fairly obvious that there may be more risks to a provider because they're not actually sitting in a room able to touch a patient and able to perform an actual examination of the patient as they would if they were in the same room. And therefore, telemedicine can create risks not only to the patient, but also to the provider. So it is very important to maintain standards of practice. And the way I thought about this was, preparing for a deposition. Anybody who wants to provide telemedicine services should prepare for the appointment, and that preparation starts before the appointment and continues up to and after the appointment ends. There have to be standards of care that are always followed in medicine, and the proposed regulations reiterate the fact that it is expected that all providers of telemedicine follow the standard of care and follow any laws and regulations and practice within the scope of their licenses. So there's no chance that anyone should be shortchanging a patient when they are providing telemedicine services. Next slide, please. Telemedicine is great, but it also has the limitation where a person may not feel connected to the provider. And so establishing a patient-provider relationship is very important, maybe a little bit more difficult to do, but if there's already an established relationship with the patient, then perhaps that person may feel more comfortable with the provider. But it is very important for anyone who is going to evaluate someone through telemedicine services that they have really good communication skills and be able to create an environment that is safe for the patient and provides for a thorough evaluation. The provider needs to be a good listener to be able to glean what the patient is trying to tell them, because every patient doesn't necessarily have the ability to communicate what they are experiencing the same as another patient might. To have a good relationship, the provider needs to be able to listen and answer the questions and to make sure that the patient understands exactly what the provider is discussing, what questions are being asked, the treatments and the instructions that are being advised. And so the provider also needs to make sure that all discussions with the patient are properly documented. Next slide, please. A provider who is going to give someone a telehealth visit or a telemedicine visit should make sure that they have access to the pertinent patient records remotely, so that they can be prepared and understand what's in the records regarding a patient's underlying condition. They need to be able to have access to any prior treatments that the patient has had, the ability to review the records and find the relevant information and prepare themselves for the visit. And that way that they can undertake a good understanding and see all of the relevant data and make informed decisions about the patient in order to decrease risk to the patient and to the provider. Next slide, please. And another very important point that Robin brought up is the fact that there needs to be collaboration. So a provider needs to be able to collaborate. A hospital can collaborate with the provider, make sure that there's access to the information that's being passed back and forth to anyone who's going to undertake a remote evaluation of a patient. And the person who is providing the services needs to make sure that they have a system in place so that they can access the records virtually for the patient that they are about to examine. Next slide. Contained in the proposed regulations is a requirement that the qualified technologies be available and that they be utilized by the providers. There are a variety of different telehealth services, including the interactive two-way communications and the asynchronous store and forward. The proposed bill contained language in the legislation that also stated that if a provider could only use audio services and did not have the store and forward technology, they were permitted to conduct an audio visit, but only after accessing and reviewing the patient's medical records. So if a provider under this new proposed legislation wanted to just have an audio visit with a patient, the legislation would have required that the provider access the records, review the records before the visit, and then make a determination whether or not they could meet the standard of care, this as if the person was actually present before they could conduct just an audio visit with the patient. Next slide, please. So the other portion to this proposed legislation indicated that if you were going to conduct only an audio visit, you had to inform the patient that they had the option of having an audio and video visit. So, you know, it's just a good barometer to understand what it is that the legislatures were proposing, so that when you are doing this, when you are going to have an audio visit with the patient, it would be prudent to offer that patient the opportunity to also have audio and video, and to document the fact that you had that discussion with the patient and made that offer to them. Next slide, please. Another requirement in the proposed legislation was for those providers who did not have a pre-existing provider-patient relationship, that they make sure to verify and document the location and identity of the individual receiving care. And that just sounds like a good practice when you're having this remote visit with the patient. Ask them where they are, document that, and disclose your identity, your geographic location, and the medical specialty and credentials that you possess. And that, again, is a prudent way to approach a remote visit. Next slide. The use of telemedicine technologies is great, but I think it also requires a type of informed consent with the patient to make sure that they understand the type of technology that's being used, and the type of information that's being passed back and forth, and to have an informed consent document that the patients can look at, read, transmit that in advance of the visit, and then make sure that during the discussion before the visit starts, that the patient has a good understanding of this of the technology being used. Next slide. And during an informed consent discussion, it would be prudent to discuss not only the telehealth technology, but also whatever privacy and security considerations are contained within the technology that's being used, and also to make sure that the patient understands that protocols are in place to protect their personal health information consistent with HIPAA requirements. So that type of information can be contained in a nice informed consent document that can be part of the patient's records, and that can be signed by the patient after the provider gives a good understanding of exactly what's going to happen during a telemedicine visit. Next slide, please. So the concept of having an appropriate examination with a patient who's not even in the room with you is really a very interesting one. And it has to begin with a review of the records of whatever you can access that's available for the patient. It's very important that the patient is able to communicate the symptoms, and for the provider to make sure that they are able to speak to the patient, talk to them and explain, here's what I understand your symptoms are, and make sure that the patient and the provider are having a good communication about exactly what that visit is about. people learn in different ways, and just because someone is, if there's a video and an audio, a person is nodding their head, a lot of times, people tend to nod their heads, but maybe are not understanding exactly what's being discussed. So during a telemedicine visit, it would be appropriate to make sure that the patient understands what's discussed, have them reiterate what they understand the provider is saying, and then document the fact that this discussion occurred and that the patient actually read back or stated back exactly what their understanding is of the information being relayed back and forth. It's very important to make sure that documentation is appropriate and that the provider documents exactly what was discussed with the patient and the decision making and what it was based on. Some other things that would be helpful is to make sure that if somebody else is present, let's say it's an elderly patient and there's someone else in the room who's helping with that communication, that it's documented who that person was and what their contribution to the visit was, and that the patient authorized this person to speak for them and on their behalf. Next slide. It's important to make sure that there's a HIPAA compliant electronic medical record that is created or updated within 24 hours. And the proposed legislation contained language that required that the HIPAA compliant medical record be be updated and created no longer than 24 hours after the visit. My recommendation would be that if there's going to be a virtual visit, it would make sense to document as much as you can, either during the visit or contemporaneously with the visit, but no longer than 24 hours later, to make sure that the information that's documented is accurate and complete, and that if there's a lawsuit down the road, the provider can actually testify under oath that these notes were made very close to, if not during the visit. Next slide, please. Having a virtual visit is so good for patients who do not have access to medical care. For the provider, it's a good practice to make sure that the diagnosis and treatment plan is documented in the record, and that this record is available to the patient. Again, contained in this proposed Senate bill was a requirement that if a patient wanted a visit summary, that it was going to be available and provided to them upon request. So having a nice visit summary available in case a patient wants a copy of it is good practice. Also contained within the Senate bill was a requirement that there be some emergency action plan or protocol in place for any health emergencies and referrals. So again, good practice would be to make sure that if you're on the phone or having an audio visit with a patient and what you're hearing is an emergency or sounds like it's an emergency and is something that was not anticipated, that there be some written protocol and some plan in place to ensure that the patient is told exactly what they need to do, and that they are able to have appropriate care that may not be available over the audio or video that's being provided. So having a written action plan, having a nice referral list, being able to have an after-hour emergency plan to make sure that patients are safely treated is important if telemedicine is going to be practiced. Next slide. I'm a big proponent of documentation. There really never is enough documentation. In any cases where we represent healthcare providers, there's always a way for someone to find something wrong with the documentation. So as perfect as it could be, a provider needs to make sure that documentation is detailed in the chart, that the details of the medical decision-making are contained within the chart, that the next steps or plans or recommendations for the patients are contained within the chart, The discussions with the patient are contained within the chart, and the information that was reviewed and taken into consideration are contained in the chart so that the medical decision making is apparent, and the fact that the provider reviewed prior records and understood the patient's condition before implementing any treatment plan is clearly documented in case down the road something goes awry or there is a lawsuit. And I think that in a telemedicine visit, the opportunity to document may even be more available because the person who is the provider may have a little bit more time to document than they otherwise might have if they're seeing patients back to back in an office. Next slide. So it's very clear based on the language in the Senate Bill 857 and even other iterations. This has been tossed around. These regulations have been tossed around for several years now. That the concern for telemedicine, first of all, with the COVID-19 pandemic, it's pretty obvious how important it is to be able to have virtual visits for patients and providers. I believe that this is going to completely change the way telemedicine is viewed. But for folks who are out in the rural or urban areas who don't have access to transportation easily, who don't have medical care nearby, where hospitals are not available, homebound seniors, people with disabilities, which prevent them from traveling easily to doctors' offices. I mean, the benefit to telemedicine is quite obvious for those patients. For the providers, what's important is to make sure that the patients are properly and safely treated, and that the provider is always preparing themselves by gathering as much information as they can and documenting as much as they can of the visit so that everyone benefits from the process.
Okay, well, we're coming up to the end of our time anyway. And so I hope you all have enjoyed this presentation and gotten something out of it. Of course, myself, Cindy Haynes, Amalia Romanowitz, we are available to answer any follow-up questions that you might think about. We're always happy to talk about this with you. We do appreciate your time and attention, and we will please look for announcements of future installments of the Women in Post to Schell webinar series. Thank you very much.